Good morning, all, and thank you for the invite and the kind opportunity to share some of my work. A brief conflict of interest. My research is fully funded by the Department of Health, NIHR, Clinician Scientist Award, and I do not have any direct conflict of interest for the topics that I'm going to talk to you about today. So for 20 minutes or so, I'm going to kind of share with you a hypothesis that I've been working on for the past few months. What I'm proposing is that we need trial-specific eligibility criteria. More than just the definitions or criteria for sepsis, we need trial-specific eligibility criteria where you're trying to link the criteria to the intervention that you're providing or testing. I think I kind of propose this broadly because of two reasons, but there are many more which I'm happy to discuss. First is sepsis RCTs usually start with a generic inclusion criteria. You need to have a clinical suspicion of infection plus organ dysfunction. That's the usual starting point. But we know and accept that sepsis is a heterogeneous illness. For example, this is a paper published recently in Lancet Respiratory Medicine. This comes from the Dutch group. What they did was to take the whole blood, take the leukocyte gene expression data, and try to identify similar patients within the sepsis definition. And what they found was there are broadly 4 subgroups or subcategories, which they call as endotypes of sepsis patients. And I think they have a different outcome, and these are the 4 different subsets, and as you can see, the mortality differs. In addition to differences in mortality, what they also show is the differences in biology in terms of the gene expression. So sepsis is a heterogeneous illness. Despite that, we use the same criteria for different trials of different interventions. The second point is much more clinical practice. Our clinical practice is now evidence-based medicine kind of approach where there is a hierarchy of evidence based on population-based knowledge. And people are arguing for kind of adopting precision medicine or personalized medicine, very similar to cancer literature. But I think if we are going to do that, we have to fundamentally rethink what we currently practice as evidence-based medicine, because most of personalized medicine is case-based reasoning. So before we could get there, there is an intermediate stage, I think, in the next 5 to 10 years, where we have to somehow understand better ways of designing and implementing trials. So let's come back to the hypothesis, and I'm going to use an example from intravenous immunoglobulin literature, primarily because that's quite a lot of my PhD work focused on B-cell biology and IVIG. And there are 2 new products in the market, and people are trying to redesign trials using more advanced kind of methods. So what I'm going to do is to briefly touch upon what is IVIG and IVIG-AM, which are the 2 products, and then try and go back in the literature and trying to understand what sepsis trials, IVIG trials have taught us, and then some of the questions and the challenges and the knowledge gap that I've addressed in the last few years. So IVIG is essentially an IgG molecule from approximately 6,000 to 9,000 donors. It consists of a heavy chain and a light chain. And remember the light chain, I'll come back to it later on in the talk. And an enriched product will have IgG, IgA, and IgM. And there are 2 or 3 products that are out there. And the mechanism for action of intravenous immunoglobulins in sepsis usually runs through for around 2 pages. You can there's toxin neutralization, pathogen clearance, immunomodulation. We don't quite know how it works. Is a simple answer to IVIG in sepsis. We kind of postulate quite a number of things. So in this background, I was one of the collaborators in a HTA grant that looked at, is there a need for an intravenous immunoglobulin trial in sepsis, and will it be cost effective if we do one? I'm just going to focus on the IVIG clinical effectiveness. I'm not going to go into the cost effectiveness part for the purpose of the talk. So when you look at IVIG trials, people have used IVIG or IVIG-AM and compared to albumin or no treatment as controls. Those are very different kind of control population. And we could also argue that IVIG and IVIG-AM, because of the product characteristics differences, will work differently. And you can compare that to albumin or no treatment in a meta-analysis, because you can account for the albumin, which is usually there for blinding of the practitioners and the bedside nurses, could be assessed as part of quality assessment of trials, like a JADAD score or some such. So you could do this comparison whilst accounting for two different products. Or you can go down the rather complicated route of trying to compare multiple things. For the purpose, we did all of these things, but I think for the purpose of the talk, I want to first focus on this comparison. So this asks a very simple question. Is IVIG compared to placebo better in the context of sepsis? And that's a simple Peto plot. You get the line of unity where there is no effect, and then there is the effect line, which is the average sum of effects from all the trials put together. And the numbers to focus on are these. Looks like IVIG does do something, and compared to IVIG, IVIGM has a slightly better effect. See, you would wonder why people aren't using this. I think one of the reasons why people aren't using this is because it's a demand-managed product and we don't quite know how it works. The doses are different. But there is also this perception that as your baseline risk of death goes up, your intervention is likely to be more effective. I think it's a mathematical phenomenon. Happy to kind of prove it outside this room. You don't need much statistics at all. But in trials, if you think about trials and IVIG effect, if you use this principle, you would expect that as the baseline risk of death goes up in a patient population, your intervention should get a bit more effective. So that is kind of possibly true in the IVIG case. But more importantly, there is quite a lot of heterogeneity in this sort of evidence, which means that we don't quite know how certain we are for the statements that I'm making. And finally, about the trial quality, using a JADAD scale, you can assess trial quality. It's a 5-point score using 3 questions: randomization, blinding, and withdrawals and opt-out. To summarize the slide, it's a messy trial literature in intravenous immunoglobulins. Small sample size, poor controls, inadequate placebo, inadequate blinding, and a number of other things. So trials thus far hasn't been great, except for probably one trial, which is the SBITS trial, which is Carl Werden, which I'll come back to later on in the talk. So that's a kind of trial literature when I started to think about the research question that I kind of hypothesis that I asked first. And I think the second issue is, after doing the systematic review and basic science, biological possibility review, we didn't know what exactly does IVIG do in the context of sepsis. And people often say it is a beautiful immunomodulator. It may well be, but not in the context of sepsis from what we know from our RCT data. So this is the SBITS trial. Carl Werden, Germany, used IVIG in the context of sepsis. And this is the placebo arm and the IVIG arm. And what I'm asking you to look at is the interleukin-6 concentrations, the soluble TNF receptor concentrations between the intervention and the control arm on day 1, day 2, and day 4. Actually, there is no difference. If IVIG was a fantastic immunomodulator, you would expect that there will be a difference between the median value on day 1 and pre and post intervention in the IVIG group, whereas there isn't much of a difference between the two. If anything, the control arm seems to have a lower value. So the anti-inflammatory property of IVIG in the context of sepsis in this trial appears to be difficult to accept. So you start to wonder, why are we doing IVIG at all? So one of the things you could argue is that there is low immunoglobulins in the context of sepsis that are trying to replace them. So is this true is a question that I asked. We did a very simple meta-analysis of published observational studies and trials which had IVIG, which measured immunoglobulin levels in sepsis patients. And the question you're asking here is, how prevalent is low immunoglobulin levels? And then the so what question, does low immunoglobulin level increase your risk of death? So the answer to the prevalence, 2 in 5 patients with sepsis will have low IgG, IgG being the most common reduction in the immunoglobulin fraction. But if you then ask the second question, does it increase your risk of death? No, it doesn't significantly increase your risk of death. So why would you replace it if it doesn't increase your risk of death? It's an argument you could bring, and therefore you wouldn't want to use IVIG because it's quite an expensive product. So then you start to wonder why this result happened. This is how research goes, I'm told. So it could be that quite a lot of the observational studies, patients had immune comorbidities, and therefore that could have confounded this whole thing. Or by measuring immunoglobulins on the day of sepsis diagnosis may not be associated with the outcome. It could be some completely different. It could be IgM as opposed to IgG, which is a research question that I asked previously. Or the lowest possible IgG level may not happen up until later on during the ICU or clinical course of illness. And actually the final point is, it may not be the absolute level, but change over time. The moment you start to think about change over time in the context of trial design, it gets really tricky, because most of the interventions in sepsis have to be early. That's what we believe. Everyone believes that. The moment you say, I'm going to delay giving IVIG up to 5 days, both the funder and your peers would look at you weirdly. So you just have to somehow understand this a bit more before you can say anything. So to address some of those questions, what we did was to do this kind of simple observational study, 100-odd patients. The key thing was none of these patients had any immune comorbidity. None of them had transfusion more than 2 units of blood in a 24-hour period. The first sample was taken within 6 hours of hospitalization, which means that pouring in a fluid and diluting the immunoglobulin molecule would not have happened. Well, that's the idea. And we measured IgG, IgA, and IgM. And I'll come back to light chains a little later on. So, first slide, IgG. Both these slides are going to be set up similarly. Survivors, non-survivors, the prevalence of low IgG levels, and then comparison over time between survivors and non-survivors. So IgG levels are low in approximately a third of patients on admission day with sepsis. And then survivors increment better than non-survivors. And that sort of a similar pattern you observe in the IgM as well. So this is remember, this is around a year and a half into my hypothesis-driven work. And you just start to wonder whether you're actually barking up the wrong tree. You know, it may be that actually it's not the serum immunoglobulin levels that is a problem here. You've got to think outside the box. It could be just the fact that the lymphocyte biology is completely scuppered, and I've completely ignored it. So that then, around the time, there was also this landmark paper published by Richard Hotchkiss and colleagues in JAMA. Jonathan Boomer was the first author. What they did was to patients who died from sepsis, they harvested their lung, liver, spleen, kidney. This paper focuses on the spleen and the lung and how the immune cells respond to external antigenic stimuli and what are the biology they can look at. So this is a cross-sectional view of spleen, and they've done a immunohistochemical staining for CD4. The reason why I bring this up is quite important. CD4 is a helper T cell which helps in the development of an antigen experienced B cells. I'll come on to that in a moment. But the key point I want to focus on is, compared to a control patient, patients with sepsis, this zone, which is the periarteriolar zone, is completely deplete of T cells, which is where the germinal centers generally sit, which is what we use from a fundamental vaccination biology to kind of make these patients immune to something, DPT, pneumococcus, whatever else. This is the key zone where they develop antigen-specific memory. And the second point is these lovely staining. They also highlight that the ability of an antigen-presenting cell to present antigen to the T cell is also impaired in sepsis. So it's a double whammy. T cells are gone, relatively acellular spleen, and the ability to present antigen is impaired. And the reason why this is important is this is what we use when you think about vaccination. You vaccinate somebody, the antigen comes through to the secondary lymphoid organ, spleen, lymph nodes, and then the B cells start to proliferate with the help of T cells, and then some T cell, B cell interacts cognitely, which results in the formation of a specific memory. And this is an iterative process. It goes between the light zone and the dark zone, and finally you get two things: a memory B cell, which is able to recall antigen in the event of a secondary infection, and a plasmablast, which goes on to become plasma cells, which produce immunoglobulins normally. So let's think about this. The hypothesis that I tested in this paper was to say, okay, the B cell subset loss is likely to be differential given the fact what we saw in the spleen of a septic patient who died. Quite a lot of flow cytometry, which essentially is coloring the B cell to try and understand what they are. You've got 6 different subsets of B cells. Transitional B cells are B cells coming out from the bone marrow. Naive B cells are normal B cells. In the context of sepsis, those B cells, transitional naive, are relatively preserved. What is lost is those B cells that depend on an antigen experience to develop. So plasmablasts are depleted, memory B cells are depleted. So in the context of sepsis, patients have got a relatively selective depletion of B cells. And this is not because of survival factor concentrations which were normal. We measured those as well. Then I did a few experiments to try and understand how do they die. There is apoptosis. And we then looked at some microarray data in the context of B cell death by selecting B cells and taking out their RNA, extracting the RNA, doing a microarray. And what we found was the activation of the intrinsic and extrinsic apoptotic pathways, in particular something that is driven by post-activation markers like a phosphorylation status of intracellular enzymes. So essentially what I'm saying in simple English is that B cells die from apoptosis and they die after activation, and the activation is not a specific mechanism in the context of sepsis. So this has got kind of profound implications. Well, at least I think so. So firstly, I think in the context of a depleted memory cell, you get in-hospital immunosuppression and risk of reinfection, which we know. And I think this is longer-term risk of reinfections in sepsis survivors, and that's something that I'm following through with a small pilot trial. So let's come back to the light chains, which I started off the talk with. The question I'm asking here is, will it give any additional information in the context of immunoglobulin biology? You can measure a lot of things, but I think what additional information does it give you? So immunoglobulin molecule is put together by combining heavy chain to a light chain by a plasma cell. What is important is that during this process of building an immunoglobulin molecule, the light chains are produced in excess of need. So there is normally some free light chains floating around. If you measure it, you will find it. But the question here is, if it is excessively high in the context of a low immunoglobulin low immunoglobulin concentration in sepsis, does it mean the assembly is impaired because you got this beautiful biology to kind of fall back on? And there are 2 different types of light chains. There is a kappa light chain and a lambda light chain, and both light chains are increased in the context of sepsis. Lambda light chain is significantly higher, and it's greater in the context of non-survival. As in, if you get a abnormal high free light chain lambda, your risk of dying is higher. So you start to kind of get to this stage where, okay, now I think I have a biomarker. This is 3 years into the first question, hypothesis. So you have a biomarker. And I think the point I'm trying to make with the next slide is, does it actually add any value to what we already knew 3 years ago? I think it's a very simple cut of the data. So what I have here is a normal IgG and a hypo IgG, free light chain kappa and free light chain lambda. What you see is a separation in y-axis is mortality. What you see is a separation between those who have abnormal free light chain lambda and normal free light chain lambda in terms of mortality. That sort of separation is not seen with free light chain kappa. And that is consistent across different immunoglobulin subsets. So to kind of come back to the hypothesis which I kind of started off with, we need an intervention-specific eligibility criteria, and we need a dominant mechanism and a causal pathway. So what I've shown up until now is that if you've got a low IgG or IgM and a raised free light chain, suggests an impaired new assembly of immunoglobulin molecule, and it increases your risk of death. In plain English, could we do a trial where you can try IVIG or IgAM in patients with impaired immunoglobulin assembly? That's the subset of patients who are likely to benefit. And I'll leave you with my summary slide. I think we need sepsis trials do need a rethink. I'm just proposing one option, which is to go back to biological rationale, pick up a dominant mechanism that you're interested in that increases your risk of outcome, and come back to it. I think the problem, I think, we will have to tackle is that because sepsis is a heterogeneous disease. You've got more than one dominant mechanism. We don't have statistical or epidemiological methods at the moment to identify dominant mechanisms to target, which is something we are all working on in collaboration with Danny Macaulay, who is in the audience. Thank you.